We move on to the last session for today, the Art of Excellence in Postgraduate Examination. Our speaker is Dr.Suhas Satish sir, MD, PGDGM, Assistant Professor of Psychiatry, NIMHANS, Bangalore. The chairpersons for this session are Dr. C. Bhaskar sir and Dr. T. Sival Ilango sir. I welcome you to the dais. Dr. C. Bhaskar sir has completed his MBBS in Tanjavur Medical College, MD in Institute of Mental Health, Chennai, and senior resident at NIMHANS, Bangalore. He's a senior consultant psychiatrist in Salem for past 24 years. Dr. Siva Ilango sir, MD Psychiatry and MRC Psychiatry. He's the professor and HOD in Department of Psychiatry, Karpaga Vinayaga Institute of Medical Sciences and Research Center. He's worked in variety of settings both in India and UK for past 16 years in general adult and old age psychiatric services. He's the assistant professor in psychiatry at Sri Balaji Medical College and Hospital, Krompet for the past 4 years, and associate professor in psychiatry at Karpaga Vinayaga Institute of Medical Sciences for 3 years. His area of interest are mental health stigma, suicide prevention, geriatric psychiatry, and dementia. I call upon our Speaker Dr. Suhas Satish sir to the dais, and I hand over the session to the chairpersons to introduce our speaker.
I think we have the last session for today. I'm privileged to introduce Dr. Suhas Satish, Assistant Professor of Psychiatry from NIMHANS. His research interest includes schizophrenia, OCD, severe mental disorders, neuromodulation, psychopharmacology, and academic psychiatry. On the research aspect, he has published 65 PubMed indexed publications so far, and for him, he has got a few awards and honors, in particular World Psychiatric Association 19th World Congress of Psychiatry Early Career Fellowship Award in the year 2019, and he was awarded with the Best Outgoing Resident Award from Department of Psychiatry, NIMHANS 2018. University Gold Medal Award for the Best Outgoing Student, MD Psychiatry NIMHANS in 2018, and Indira Gandhi Nation Open University Postgraduate Diploma in Health and Hospital Management, University Gold Medal in 2015. So we have a very eminent speaker for this last session. I'm sure we all become competent so far. Now he is going to give us some strategies to excel in the examinations. So over to you, sir.
Thank you, sir. Thank you very much for that kind introduction. So I know that I am keeping you from your lunch and keeping you from your travel back to your busy workplace, wherein your colleagues have already taken over the cases. They are waiting to hand those cases back to you. And so I won't take a very long time. What I am actually going to do is talk about the art of excellence in psychiatry postgraduate examinations. Now, this topic is something that I speak from the heart, and it is very, very important because all this while for the past couple of days you have been listening to the knowledge-based competencies regarding psychiatry postgraduate examinations. Now, how to take a case, how to take a long case, what about the radiology findings, what about the neuropsychological assessments, personality assessments, so on and so forth. Now, let me take you quickly through what you can do during your postgraduate residency so that you excel in your exams. This template is something that I have actually written from my own experience of my teachers, and experience of my students as well. Hope you find it useful. And at select part of the presentation, I would encourage you to take out your mobile phones and take snapshots of some of the slides that I'm actually putting through. My gratitude to the Indian Psychiatric Society Tamil Nadu chapter, Dr. Panneer Selvan sir and Dr. Noorul Hassan, my young colleague from NIMHANS and who is now here in Tamil Nadu, the organizers and all the students of psychiatry. So what is this presentation about? So this is a template for excellence in psychiatry post-graduation. I will share some tips, some templates, and also some pointers as to how you have to go about preparing for your examinations, which will be helpful for you in the long run. What it will not cover is something that has already been covered. For example, I will not talk about the long case and its management, because yesterday comprehensively it has been covered, isn't it? Second, I will not cover the neurology case and management, and I will not be covering imaging related aspects and psychological assessments. Okay? So there are 3 labs in your post-graduation, isn't it? The 3 years. So the first year, semester 1, you want to gain core competency in a few select principles, that is interviewing skills, history taking, basic neurological examinations, fundamentals, psychopathology, classificatory systems, basic neurosciences, and basic psychology. All of us know this. And you also actually have to gain some research competency, especially in protocol writing and finalization. By which this time, all of you, because most of you, I'm informed, are from second year and third year of post-graduation, isn't it? Am I right? How many of you first years here? Can you lift your, okay, there's a sizable amount of first years also. I'm glad, because this presentation is also for first years, including second and third years. One of the important resources you have to comprehensively cover in your first year is FISH, SIMS, ICD, DSM. So these are the basics and fundamentals of psychopathology and classificatory systems. And once you have mastered these things, you can go on towards the research domain criteria and the high-top classificatory systems. So the first tip I'm going to be giving you today, I'm going to be giving you 15 tips, which are likely to be very useful going forward. So the first tip I'm going to be talking about today is use your immunity in the first 6 months of psychiatry very, very well, right? So irrespective of what silly doubts comes to your mind, please feel free to ask your senior resident, and please feel free to ask the same doubts to your consultant as well. Because you will not have this immunity after 6 months. I'm sure all the second years and third years will agree that after you reach second year, you'll be like, this is not a doubt I want to ask my consultant. What will he think of me? What will she think of me? Maybe they'll think, this fellow doesn't even know this. So you kind of become a very diffident character in your second and third year. So first year, first 6 months, full immunity. Ask everything and anything. Sir, why have two different fields, psychology and psychiatry? Why not merge it into one? Sir, psychiatry is a pseudoscience, sir. Why are we doing this? Ask anything and everything you want to ask. First 6 months. Okay? That's tip number 1. Tip number 2, learn from your seniors, and most importantly, learn from the mistakes of your seniors and their experiences. So in clinical rounds, you would be wondering when you are actually, your senior is presenting some complex PTSD case and some comorbidity case, and you're left wondering, okay, he is presenting something, they are actually kind of talking to each other. Let me just quickly check my Twitter feed. Let me just quickly check my WhatsApp messages. Is there anything else that is there? This is on TikTok video, which is very funny. Let me just kind of do that. While the temptation to do these things are there, please mind that every minute and every hour that you spend in clinical case presentations and learning is going to be immensely, immensely useful. So make it a point that you actually learn from your seniors' mistakes and talk to them as to what worked for their examinations, what did not work for their examinations. You will be surprised to know that many times the mistakes that they have committed will actually be committed by you if you do not actually check with them as to what went wrong or what went right, and so on and so forth. So tip number 2, you will speak to your seniors more. So by the first semester, you need to develop excellence in few select parameters, and those are: 1, history and evolution of psychiatric disorders. This is very, very important. All of you will be very good in history taking, very good in ICD and DSM and SIMS and FISH. But what you have to develop is a competency as to how the current constructs of psychiatric disorders evolved. What we understand as schizophrenia now was not just handed over to us. It is through years and years and years of dedicated efforts of the scientists who came before us that we know what we know right now. So it's important to understand the evolution of these concepts. It is also important by the end of the first semester to understand the social and the cultural interface of psychiatric disorders, and to finish your neuroanatomical and neurochemical foundations for your psychiatry. Because afterwards, once you come to second year and third year, you will not have time for these. And now you are blessed with enough resources available on the internet. There are extremely good courses on Coursera, Udemy, wherein you can actually enroll for these courses for free and learn neuroanatomy and neurochemistry. And these are visually rich, appealing, and will also have a pre and post test to test your competency that you have gained about these basic foundational courses. You have to, please take out your phones. This is the first slide wherein I want you actually to take out your phones and then take a snapshot of the slide. You have to have competency of these seminal articles by your first semester, if not by your second semester. If you are in your second year or third year of post-graduation and you have not heard of these particular articles, you are in trouble. So what I would recommend you to do is go back today only and finish reading them off. First of which is the Rosenhan study on being sane in insane places. And then you go on to talk about the UK-US study, and then Robbins and Goose criteria for classification of psychiatric disorders, and then the dreaded Fools hierarchy. How many of you have heard of Fools hierarchy? Fools hierarchy, your faculty would have asked you what is Fools hierarchy of classification of psychiatric disorders. Okay. So, Fould and Bedford hierarchy of classification of psychiatric disorders is very relevant to ICD-10. We know that if a person has schizophrenia, we do not make an independent diagnosis of a dissociative disorder. We assume that dissociative experiences might be a part of schizophrenia itself, isn't it? We know that if a person has mood disorder and dissociation in between, we again don't make independent diagnosis of two separate disorders. All these knowledge was given by Fould's hierarchy, and which is based on botanical principles actually. It's very interesting. Go back and read about it. So you have taken snapshots of this slide. Let's move on. So in semester 2, you have to gain competency of a formulation. You have to become an expert in formulation. A formulation is fundamentally different from a summary. Summary is wherein you are just saying that a male, so-and-so male, pre-morbidly well adjusted, presented with so-and-so history of so many years and had MSc, these findings. That is just a summary. A formulation is the way you are conceptualizing the case as to what are the precipitating factors, the cultural factors, perpetuating factors, personality factors, comorbid factors and protective factors in this individual, and how I plan to go about helping this individual. So when you are making a formulation, essentially you are speaking about yourself as much as you are speaking about the patient, because the examiners are trying to understand how well you are able to understand the person who is there sitting right in front of you. Okay? And you'll have to develop a mastery over this, and this happens only by practice. Then you'll have to also gain some research methodology competencies, diagnostic and therapeutic skills, and fundamentals of psychotherapy have to be covered. You might also want to use this time in second semester of your post-graduation to join social networking channels wherein learning is happening continuously. For example, one such network that we are involved with is called as TIPS, wherein we run a Telegram channel wherein we post sessions every day, questions every day, and we have special sessions designed for postgraduate training every once in a while, which will help postgraduates. Most of our content, in fact 99.9% of our content are available for free on the public domain, where we have prepared notes also which should help psychiatry postgraduates. Do check it out if you haven't heard of this. Tip number 3, avoidance is to be avoided, right? So what you do by second semester or the second year of your post-graduation is, you have taken a detailed workup, 2 consultants are sitting, and one consultant is very strict, likely to come as your examiner. The other consultant is very, very ADHD, right? The other consultant says, just finishes the workup in 5 minutes. Your tendency is to go towards first one, second one. Second one, avoid this tendency. The second consultant also will have lot of things to teach you, no doubt, because in a span of 5 to 10 minutes, they will conceptualize and teach you. But the first consultant, who is actually taking the time out to critique you, to rip your history apart, to spit at your formulation, to throw your management plan, is actually helping you. He is helping you. Don't worry about how it will look in front of your colleagues. It's fine. We've all been there, right? Do keep on presenting more and more cases to the so-called strict examiners and faculty. You know why? Because once you keep facing them, by psychological learning principles, when you go and face them in the exam, you're not afraid anymore, right? Already he has spat at me, tore my paper, and called me a fool in front of my colleague. What else he can do? But you would actually realize through these very emotional experiences, you know what he is expecting or she is expecting. You know where your loopholes were. And so when you do not repeat your mistakes, he will pick you out as gold among all the other people who will still be in a charcoal phase, right? So it's very, very important not to avoid, okay? So 3 tips already over. So in your second semester, time for the phones to come out. So this I am doing specially on the request of Dr. Nurul. He said, sir, we want a list of all seminal articles that our PG should actually read and learn about all the concepts of psychiatry. So we made a collation of all this, and I'm sharing this with you. So by first year, you should have finished your basics of psychotherapy, whether psychotherapy works, what are the general factors of psychotherapy, what is meant by person-centric approach in psychotherapy, and why does every psychotherapy work, and why the effect sizes are almost same for all psychotherapeutic measures. Right? This is something that you need to cover within your first year itself, and get fundamentals of psychoanalysis also out of the way. You are also introduced by the end of first year into biological psychiatry. Biological psychiatry is as much a serendipity as much as it was intentionally discovered, which means to say most of the wonderful things that has happened to us has happened by accident, and it is good. So make it a point to go about reading these articles as to how it happened for two reasons. One, to understand as to what are the gifts that we are blessed with today and how it evolved. Second, because examiners like this. They have actually gone to the depths of the knowledge and they want to test it, especially in your Viva, as to whether you know about all these historical connections to the rich science that we are actually practicing today. You also want to go and cover some fundamental evolution of neurotic states and disorders and how it has evolved to the current construct. That also needs to happen after the end of your first year itself. So by the end of your first year, essentially you would have known all major psychiatric disorders, their diagnostic criteria in ICD-DSM, and also you would know as to when I reach this stage of DSM-5 text revision or ICD-11, I know how it evolved from scratch. So now I know fundamentally that when I elicit a psychopathology, whether this is related to a particular disorder or another particular disorder. For example, if you read these articles, you will come to know, can anybody tell me how will you actually differentiate, say, a hypochondriasis, right, wherein a person believes that they have a disease, versus an OCD wherein they have a fear of contamination of getting, say, COVID? Anyone? Anyone? Just one attempt. Or a somatic symptom disorder, wherein people go on about their complaints. So go back and read these articles and you will understand the fundamental underpinnings, right, wherein in one you will understand the focus is on the experience. The focus is on the distress that is associated out of these particular bodily experiences. In the other, it's the fear of an unknown disease. So whereas in the one, there is a lot of focus on the dreaded disease and investigations for the disease and going on doctor shopping for the disease. In another, there is an elusive hunt for relief from the bodily symptom. So these kind of core fundamentals you will get once you read these articles, right? Go back and do that. You should also get an understanding about the interface between anthropology, culture, social sciences and psychiatry, and that can only happen at this particular stage because after about 1.5 years into your residency, you start having more and more commitments towards your patients, your theses, and so on and so forth, and therefore it is a very good idea along with your basic neurosciences and basic psychological sciences to cover these aspects of. I have again shared a few seminal articles over here. So at the end of 1.5 years, you would know the differences between a disorder and a disease, isn't it? Anyone? What is the difference between disorder and a disease? Anybody? Okay. Why are psychiatric illnesses called as disorders and not disease? Excellent, excellent, excellent. So it is very important to understand, whereas malaria is a disease, because if I take 5 malaria parasites and inject it into all of our blood, all of us will get malaria or at a high risk for malaria. Whereas with respect to an etiological basis of psychiatric disorder, there is no monocausal etiological basis. And therefore, although we know that there is a lot of multiplicity of factors predisposing to psychiatric illnesses, and although we know the course and outcome of psychiatric illnesses, we call it as disorders and not disease. And this is a fundamental concept by the end of first year you should have gained, right? And then you also gain understanding about validity of psychiatric disorders, Robinson Goose validators, right? Nancy Andreessen validators, and how the psychiatric disorders actually got their validity, including the dreaded US-UK study, which you'll be asked questions on. You also should have gained competency into what is the dimensional versus the categorical classification of psychiatric disorders or symptoms, and how it is useful for us, which are the illnesses or the classificatory systems which take a categorical approach, and which are the ones that take a dimensional approach, and is there any classificatory system which takes a dimensionality within a categorical approach? Are you aware of anything that takes a dimensionality within a categorical approach? I don't know, which classificatory system, like DSM, ICD? ICD-11, isn't it? Wonderful. So we know that, right, we call mild, moderate and severe kind of a dimensionality within the categorical actually classification when we say minimum these number of criteria should be fulfilled for a depression. Very good. You also have to understand operationalization, because a fundamental concept is psychiatry has a lot of symptoms which cannot be concretely evaluated like your blood pressure or blood sugar, right? For example, if I ask you, how much do your parents love you? What will you say? So much. Some of you will say very much. Some of you will say more than anything in the world. So there is a whole range of criteria that you are actually given. Because psychiatric symptoms and signs can also have differential interpretations of the distress. Therefore, the classificatory systems have evolved what is called as operationalization of these distress, and that is a concept that we have to gain competency for. We also have to understand nature, nurture, and a theoretical concept. Anybody can tell me what is a theoretical construct of psychiatry? Okay, let me give you one example. One person, a young male, goes to IIT after having cracked the exams, and then in IIT, he has a relationship failure, also actually is indulging in cannabis, and then goes on to develop depression once his thesis protocol has failed, right? Would you call it as depression? How many of you would call it as depression? He satisfied syndromal criteria for depression. How many of you would call it as depression? How many of you would say, hey, this is normal? Like, he has obviously had so much stressors. Obviously, I expect him to actually go through what he is going through. Oh, so all of you are waiting for your SR or consultant to give the verdict, is it? Choose one, come on, right? How many avoidance, see tip number 2 or 3, you remember avoidance should be avoided, right? So, how many of you would call this person as having suffering from depression? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. How many of you say, no, it's not depression, it is normal? 1, 2, 3, 4, 5, 6, 7, 8, yeah, around same. It is important to understand that one of the fundamental concepts of psychiatry is a theoretical basis, which means to say we do not go into the why behind the what, because inherently I can understand it differently. Like I can probably think that it is probably normal, he is going through so much stressors at once. Other person might say, no, it is not normal, he is having his protocol has failed, tomorrow he might be at a risk for suicide. Already there are a lot of people at IITs who are actually having these disorders and they are actually attempting suicide. So therefore, a theoretical construct, which is a fundamental construct in psychiatry, means you do not ask the why. The person, if he meets criteria for a disorder, he has the disorder. That's it, full stop. Okay? So all of you who said, yes, he suffers from depression were right. Okay? Because he satisfies criteria. It is given out there, he satisfies the criteria, he satisfies the duration, he has the disorder. That's it. Practically in your practice, you might want to tweak this a bit and try to be aggressive in people without stressors, whereas try to be slightly lenient in your approach if they have acute severe stressors in how you actually go about things. Okay? But for a fundamental concept, you have to know that it is a theoretical nature. Bradford Hill criteria is something that you must actually know very, very well, because in your exams, your examiners will actually give you a case of depression, cannabis use, and also the person having a recent road traffic accident. The person is actually having depressive symptoms, neuropsychological deficits, aggression, right? And you do not know, where do I put this? Do I put this in depressive disorder? Do I relate this to an amotivation related to the cannabis use? Or do I actually call it as a neuropsychological deficit syndrome arising out of an RTA? When you have such complex questions in your mind, Bradford Hill criteria is the key. Bradford Hill criteria, originally given after Cox postulates came about, spoke about how do we associate a cause from an event, right? It cannot be that every cause is an event. For example, I came here, half the hall was empty, right? There are a lot of things that are associated with this. The lunch was open, some of the people wanted to collect certificates, some of the people wanted to leave early. So quite clearly these cause and events are not related to each other, isn't it? Bradford Hill gave about 10 criteria wherein they spoke about how do we actually associate the cause and the event so that you know for sure that it is the cannabis which has led to this particular problem, or is it the RTA that has led to this problem and not the primary diagnosis of a schizophrenia or a depression. So will all of you go back and read about Bradford Hill criteria today? Very good. And you also should be very competent in doing a multi-axial diagnosis. So there is a lot of knowledge domain parameters that you will gain in your first year. and skill domain also in eliciting psychopathology, taking history, which you'll actually gain in your first year. And by year 2, you will come to gaining competencies in de-addiction, geriatric, child, and forensic psychiatry, which is very, very important. Of the base subspecialties and parallel specialties, you have to develop competency in these 4 first and then go on to the others. You're also going to finish off the most of your psychotherapy sessions, and this is the time wherein you move from your textbooks to gaining more and more repository of monographs and subspecialty books, which you can cover and make notes which are going to be helpful in your third year. Please do not start reading any new textbook when it is 6 months to go for your examination. It is impossible, right? For example, some people say now 6 months to go is there, I will open my new CTP. And then, first chapter I will open. And then you see the small print, like one kutti print they would have written. And then you are like, what is this? Everything seems Greek and Latin. And this, what is chronobiology? What is neurobiology of consciousness? Oh my God, right? You study it for 1 week, it is not enough. 1 month, it is not enough. You keep reading about it, isn't it? It's very, very important. Starting from second year itself, you should start making notes. So skeleton notes has to be prepared for all the topics that you are actually doing. Second year is also the key for you to finish up your review of literature and finish recruitment for your thesis, because that is how you will get free to study for your examinations. So you might be wondering, what is this person coming and talking about thesis in a topic on exams? Primary prevention and primordial prevention. Remember, risk factors should not develop. You should not let risk factors and disease to develop before you intervene. That will be only secondary prevention. So for all the first years out there, I'm giving you primordial prevention techniques also. Tip number 4, giving due importance to community psychiatry, forensic psychiatry, rehabilitation and neuromodulation is absolutely essential. Absolutely essential. You will read everything about neurobiology and go to the exam. Left, right, center, Kane's article, and then, what is the optimized trial, and what is amisulpride versus olanzapine, long-acting injectables, and Lloyd's meta-analysis. And then the examiner will say, give me the principles of NMHP. And then you are stumped, right? You are stumped, and they want to stump you through this. This question is asked ranging from your postgraduate exam, SR interview, to even faculty interview. I was asked this question in my faculty interview. Thank God I had these tips handy, because I had covered it and I was able to answer it in my faculty interviews as well. If you do not read community psychiatry, it's a sin. Staying in India, if you do not read community, it's a sin, because we are where we are right now because of what our predecessors did and where they have brought us over here. Because at that point of time, 20, 30 years ago, nothing was there. Systems like this was not there. And still they are helped our patients who are there suffering from psychiatric disorders. And therefore it is very important to talk about all these landmark Bellary model, Raipur Rani, Sakalvara model, NMHP, DMHP, how it evolved, why was the pilot done in Kolar of all the places and not anywhere else, right? What makes Kolar special with respect to its demographics that people chose Kolar, right? These are important questions that should come to your mind. And that is something that you should be concentrating on in your second year. If you want to be excellent, if you are one of those candidates who are like, sir, I am planning for gold medal. In my first year itself, I have decided my name, next to it, there should be gold medal. How many of you are planning for gold medal? Come on, lift your hands. Avoidance is not good. Be self-confident. Lift your hand. I was aiming for a gold medal. Okay, I am telling you the truth. How many of you are aiming for a gold medal? None of you? Very satisfied? Right? Okay. What I mean to say when you are aiming for excellence or a gold medal is, please do not stop at reading only the knowledge related subject only. No, read about memoirs, read about autobiographies, read about biographies, because that's what makes your skills and knowledge very, very rich. You would have had these experience, no? You have read everything, you think you are a good student, you will go to some international conference and then in high fundu English, somebody will be telling, right, in John Forbes Nash Jr., in their pathological experiences and how it actually influenced their family and what it meant. And you will be like, what are they talking about, right? For you to be relevant in an increasingly connected world, you should not neglect patients' lived experiences, okay? Lived experiences means books can only tell us so much about what is psychiatric disorders. Lived experiences are people who have suffered from it and what they have written about it. And that can only be obtained through books and more books. Some movies also, but mostly books. Okay? Will you all go back and try to read at least one of these books in the coming month? How many of you will at least try reading one of these? Okay, good. Tip number 5, see one, do one, teach one once you are a senior. Golden rule. Once you are in your second year, you have the luxury of having your juniors come. Okay? That is a double-edged sword. So what will happen is you will be sitting in rounds. Psychopathology question, the first year will be asked. Tell me, how do you differentiate delusional misinterpretation from primary delusion? I'm like, first year. And then he doesn't answer, it will be shifted to you. Right? Then you're like, oh shit, what do I do? This thing. Why this fellow didn't answer? Why this thing? And then this first year won't stop. He will go on and on. Sir, psychopathology is like this. And then you are left wondering, what are we, and then because questions keep coming to you. Right? It's very, very important that if you have those experiences, right, go back, read, teach to your juniors, and then talk about why it is a particular psychopathology, particular disorder, particular management plan that you have chosen, and also keep practicing these skills every now and again, right? You would have had these things, no, Aaron, that at some times that in front of your juniors who is supposed to shadow you, you are like, okay, I will show you how to do history taking, you will go, and then suddenly the patient gets aggressive or starts crying. They are not stopping to cry at all. Crying, continuously crying. And you are supposed to teach this fellow how to take a history within 1 hour. Okay, 45 minutes this patient is crying. Unless and until you go back and learn how to manage a crying patient, about which there are some more seminal articles written, you won't know that. And if you don't know that, you won't teach it to your junior. And therefore the cycle of mediocrity continues. So it's very important that if you are stuck in those situations, make it a point, go back and read, and then teach your junior, right? Tip number 6, be process oriented in your learning. Sometimes you would have put in your best effort. Till 11:30 you will clarify the history, and then you will sit and you say, yes, I have cracked this history, Bradford Hill criteria, that criteria, everything I have applied. Tomorrow in consultant rounds I will show. But then tomorrow in consultant rounds, the history will become ulta. The patient will come up with some bizarre new things. Then diagnosis will change from neurosis to psychosis. And then you are left disappointed and dejected. And you said, it is useless. Best is not to do detail workup at all. Let the consultant come do whatever they want to do. And then after their diagnosis, I will write my detail workup. That is the best approach. No, that is not the best approach. It is good that you become process oriented. Keep trying, right? The more you keep trying and failing, it means to say that you are refining a part of yourself. Only then will you actually keep getting better and better and better at what you do. Excellence at the end of second year, you should become a master of psychopathology. Primary delusion means you should say, tuck. These are the primary delusions. And how do I differentiate from delusion of misinterpretation? Sir, delusion of misinterpretation. Before that, there will be some other delusions or some other psychopathological state. So they are not secondary to something, whereas primary delusions arise de novo. They are not secondary to any other thing. I cannot further deduce it. Therefore, this is a primary delusion or this is a delusion of misinterpretation. Once your fundamentals get that strong, your third year is taken care of. Then you should also read about psychopharmacology. An easy way to read psychopharmacology is as soon as you get up, right? You should have one book right next to where you sleep, prescriber guidelines. All of you have prescriber guidelines? Stall's prescriber guidelines? Prescriber guidelines and Maudsley are your second year companions. In third year, they should be your ex. Okay. Second year, they are you should do double timing with these two books. Okay. Every day you should get up and read 2 to 3 pages, at least 2 drugs and 2 to 3 pages of Maudsley. You should become so good at it that you actually develop some 2 or 3 points about this particular drug. Okay, buspirone. I know that in my center we do not write a lot, but it is used between the ranges of so and so. What is unique about its action? In which indications is it used? What are the unique adverse effects? If you just know 4 points about each medicine, mind you, by the end of your third year, you are standing on very, very firm and strong ground. If you do this the other way around, if you wait till your exams, right, and your exams are coming and then buspirone, bupropion, buprenorphine, my God, what is what? In my exam I am confused, do I write buprenorphine for this one? So for that not to happen, you have to study your prescriber guidelines and Maudsley in your second year, right? You will have to also know the statistics related to research. Now, statistics is like swimming. How much ever you study about swimming through book, you will ultimately have to get into the water and then only learn swimming, isn't it? So it's impossible to just learn swimming through reading as to how swimming is in books. Statistics is also like that. So what you need to do is pick up a few papers that are recently published. Discuss with your juniors and seniors, and also on forums like the e-Journal Club of India, wherein you'd say that these are the things, I don't understand what the statistic is. Can somebody explain this to me? It might be simple t-test that you are confused about. You might be just confused about what is a student t-test versus paired t-test, I don't know. But you are too diffident to ask. Mind you, it is better that you ask now than 2-3 years later when you are a senior resident and your consultant tells you be a co-guide or a mentor for another thesis. Then your student will come and ask you, sir, you are a co-guide, kindly so long this t-test, student t-test, pair t-test. Then you'll say first you'll have tea and come. And then we'll talk about all this. And then while he's having tea, you're doing some jugad on the phone, like, okay, what are these things? So very, very important to avoid all those embarrassing situations. Keep learning these things in second year. Start subscribing to journal updates. SkyMago is an online source which ranks the top journals in each specialty. You just go to SkyMago, you say psychiatry. You will get top 10 or 20 journals in each specialty. Then you subscribe to these. Subscribe means to say, you just give your email and say, you send me whatever alerts that you get. The mere watching of all the topics and being updated as to what is the current research helps in your final year or final year examinations. Very, very important to do that. And you have to read all relevant legislations and amendments, especially the MHCA 2017. So important for your PDF, postdoctoral fellowship entrance exams and any other senior residency exams. They like to torture you on this. Like State Mental Health Review Board, who are the members? And then, what is the other committees that are there? Who are the members? The district judge is there in which of these two committees? Which state it has actually developed? So all these finer, intricate details, they try to torture you. So that you cannot actually wait till your final year wherein you are more focused on core psychiatry to actually read all these things. So do it in your second year and get a competency over that. Tip number 7, landmark studies, especially from India, are very, very, very important. You don't know some international optimized trial, you don't know some Lloyd meta-analysis, Cipriani meta-analysis for depression, doesn't matter. Indian studies on psychiatry are very, very important. Photo. So, among all the Indian studies on psychiatry, you have to go back to the roots and talk about what Professor Vidyasagar did for psychiatry, what Professor Neki did for psychiatry, what is this Guru Chela concept that they spoke about, what Professor N.N. Wig spoke about when he told about this Hanuman complex, and what did he speak about the expressed emotions in schizophrenia and that syndrome, so on and so forth. And parallelly, you will also need to understand the landmark articles that are published in Indian psychiatry space. For example, Pilowski's abnormal illness behavior, which to date remains as one of the best articles written on this topic, was actually published in Indian Journal of Psychiatry. So it's important that you know about these stuffs and are well versed with it. You should also know about psychotherapy in the Indian context and what has been written about it, and all the famous studies that have, in fact, Tamil Nadu is very famous for conducting some of the best community psychiatry studies, and not one, not two, but several. So it's because one of the centers was always in Tamil Nadu, isn't it? So it's important to actually know very much about these studies, right? So over the past 3 to 5 decades, of course, you have some other studies that have become very, very important, including some Indian studies that you will have to be again well versed with. But read that after you have mastered the Indian studies. For example, DOSMED study, which is the WHO 10-country study, then the Madras longitudinal study, KT Cutlass, EU Fest, Optimize, Embolden, Boulder 1 and 2, Step BD, STAR-D, and Dunedin cohort study, which is very famous for looking at the exposure to cannabis and what happens to them at a later on in life. The bipolar schizophrenia intermediate phenotype study, and the intercept study for suicide. All of these things are important because once you read them, you will understand facts and figures which are necessary to understand numbers which will come in handy for your Viva in your examination. So by the end of year 2, you have core psychiatry expertise, you have subspecialty expertise, you are well versed with the neurological examinations and psychopharmacology, and you are well versed with psychotherapeutic methods also, advanced psychotherapeutic methods, including psychodynamic psychotherapy and some other different indications. Now coming to year 3, which is very, very important. Some of you are already there. You are aiming for mastery. Here, it is important that you already have started developing a comprehensive skeleton notes for all topics. For example, the same thing we spoke about, chronobiology in bipolar disorder, affective disorder. You should have at least a 10-point notes for chronobiology of bipolar affective disorder. Now, what is clock genes? What are the studies that are done in mice? And why it is important in bipolar? How do I link it with the interpersonal and social rhythm therapy? What is the social rhythm component of this particular thing? And what is the light therapy and how does it work in seasonal affective disorder? Once you start making these skeleton notes and start linking the neurobiology to translation efficacy, it starts becoming very rich to you. Subject starts appealing more and more to you. Then you start thinking, why haven't I tried light therapy for my patient? Why haven't I tried sleep deprivation therapy for my patient? Not saying that you should do it tomorrow. Your consultant will scold you. He has come to a hospital to sleep. And you are saying, I'll deprive him of his sleep and then I will continue. No? But what I meant to say is, know about these things so that you will be able to practice psychiatry for all the richness that it is there. You'll also need to gain exposure to imaging and EEG. And please read previous year's question papers. Some of you might say, I don't like all those things. I read CTP and I'm prepared for any question that comes in the examination. Please don't be so reductionistic that that psychiatry can be understood from CTP alone. No, the previous year's question papers are a template for what your examiners think are important for you to know, and you will come to know about these topics only once you read it. So you should not read previous year's question papers with the sole intention that I will read only that. But you should definitely read it because you know what are important. So that people who have sat and kind of, prepared the questions for your exam have done it with a lot of forethought. They think that this is important for my students to know. So please do read it. And it will also give you an idea about what are the benchmarks at which you can actually progress. For example, if by the end of your 2.5 years of residency, if you have not finished at least previous 10 years question papers, if you are not well versed with the topics, you are slightly at risk. And at the end of 36 months, know that if you have done most of your work properly, you will know more than most people in first year or second year, and you need to trust your instincts on the same. So tip number 8. Nowadays, there is a vast digital repository of knowledge that is there everywhere. Every day you actually get one email or the other saying that Monday there is one particular meeting, Thursday there is a musing, and 2 weeks later there is a Zoom meeting, 4 weeks later North Zone is doing something, East Zone is doing something, South Zone is doing something. For you, you are a learner. There is no zones. In fact, you transcend boundaries to even outside of India. So anything happening internationally you feel is important, subscribe to it. Go attend that Zoom lecture. Subscribe to all the channels which are putting in content which are important for postgraduates. For example, VKN and NIMHANS Digital Academy have some hundreds of videos. So it is very, very important to kind of subscribe to it, which will become helpful. Tip number 9 for final year, very, very important, is all the seminal articles that I am going to show to you, you should be well versed with it several times. There should be no way that you have not heard about these articles. If the examiner thinks you don't know about these articles, you are in danger. So photo. So I'm obviously not going to go through all of these articles. I have put this up so that all of you are aware of these articles. Go back to your library, find out the original source. If you don't find it, you can always email me, I'll send it to you. But first try to dig it yourself and then be well versed with all of these articles. Because if you don't know about them, you are slightly on shaky ground. Yeah, so this I think is last of the seminal articles that I was talking about, wherein NMHS is something that you should know by heart. Like it talks about the prevalence of psychiatric disorders, the treatment gap of psychiatric disorders. But very, very important for you is to know the latest World Mental Health Report that has been published in 2022. Please go through it because it gives important perspectives about mental health as well. So tip number 10, know your exam pattern. Very, very important. How many of you know what is the total marks in your MD final examination that you will be attempting? 1. Very good. How much, ma? Total marks. Very, very good. Out of a hall of 100 people, potentially 100 people, one person knows what are you fighting for. See, when you enter a cricket match, as a, when you are batting second, you should know what is the target that you are chasing, isn't it? If we are oblivious to what we are actually chasing, we will think that something they will keep giving spotters, OSCE, NNMO, they will keep giving, and then I will try doing something and then I will see. Very, very important for you to know the exam patterns. Your total marks is around 700. So this is specifically to Tamil Nadu that I am talking about. I am not giving the NIMHANS marks distribution. So out of these 700, you got 4 theory papers of 100 marks each, which is around 400. And then out of which you should obviously get 200. There is a long case for 80 marks. There is a short case for about 70 marks. And there is a logbook for about 20 marks. There is a written OSCE or a spotter for 25 marks. Very, very important. You know why? It is important because nobody can take this away from you. No matter if the person examiner hates you, doesn't like you, it doesn't matter. Spotters is something that you write. And they will usually be 1 point answers, isn't it? You have written, it is Rorschach ink blot test. Done. This is the variant of Rorschach ink blot test. Done. You should get that particular marks. So essentially, these 25 marks should be in your kitty. It shouldn't even give an inch of this 25 marks. That is why it is important. Clinical OSCE is for 25 marks. I call this as a second chance in psychiatry post-graduation for you, examination-wise, practical examination-wise. You know why? Because examiners, when they are looking at your knowledge and skill domain, first if you have goofed up on the psychopathology, if you have goofed up on the diagnosis, they are slightly on the borderline thinking that, okay, what should I do? Should I pass this or not? But when it comes to clinical OSCE, and then they gave a task to you, assess suicide in this individual, and then you do a perfect OSCE. You actually follow all the principles. And then for 10-15 minutes, the patient opens up to you, and then you summarize everything, and then you look at the examiners, they'll be more than happy to pass you. You know why? Because latency effect. You know what is latency effect? It's a psychological principle. If I ask you to remember 4 or 5 numbers, okay, 90563, 29198, right? Most of you will say 29198. Why? Latency effect. Because your brain has recorded the most proximal information, isn't it? Therefore, OSCE is likely to happen at a stage wherein you're done with your long case. So examiners, if they look at good clinical skills that are being there, then they will actually are likely to pass you. Don't forget this, that's why it is important. Viva voce is for 80 marks. 80 marks. You know how much 80 marks is? It's as much as your long case. So while you worry the entire 3 years for your long case and you neglect everything else, you are doing a great injustice to yourself. And this knowledge, just now what I presented, is there in the public domain on your Tamil Nadu medical board website, and even in fact if your seniors would be aware of it. Very, very important to know that. So the art of excellence comes first by knowing what am I fighting for, where am I headed towards, what stage of my career am I in, and what I should do to get where I want to go. Logbook is 20 marks. Don't neglect it. It is also a lifesaver because if you are on the borderline and the examiners are thinking, should I pass this person or not? If your logbook says 8 out of 20, fail. If your logbook says 14 out of 20, 16 out of 20, you say 3 years this person has actually worked. That's why logbook says 16 or 18 out of 20, they will consider. No, it is very important. They will think that this person is sincere. So in senior residency, they will pick up whatever deficits are there. So take logbooks also very, very seriously. Just before the theory exams, very, very important, good food and a good night's rest. Nothing beats this, right? Previous night also you should have good food. On the morning also, you should have a healthy breakfast. Very, very important. And at least 7 hours of sleep is something that is extremely important. Then subsequently, the last 1 month of your theory exam time, you should have skeleton notes. There are these printouts or one booklet that you should do, wherein each topic, treatment-resistant schizophrenia, right? For example, if that is a main question, it should have 10 points. Number 1, what is the definition of treatment resistance? Number 2, cane content, modified cane content. Number 3, Suzuki criteria and the TRIPS guidelines. Number 4, close-up in and a JAMA Psychiatry article in 1986, which was then called as the Archives of General Psychiatry, and then you should actually kind of talk Archives of Mental Health, and then you should talk about what are the clozapine initiation strategies, treat clozapine augmentation strategies, and what is ultra-resistant schizophrenia. If you have about these 10 headings when you are asked a question related to resistant schizophrenia, you already are done. In the exam, you won't worry about where do I start, where do I end. Your skeleton notes will actually come as a template, and you will finish that particular question. Do not discuss the day before or on the day of the examination with your friends. They'll be only talking rubbish. Some of them will come and say, Cummings, you have read, huh? Cummings. Cutting psychopathology examiner is asking, have you read Cutting Psychopathology? And then they will come and then you are like, I have finished CTP. Which book? Tasman. Tasman is waste, bro. What? You have read 3 years Tasman. So suddenly all these unwanted, critical, unhelpful comments will come one day prior. Please don't ask about your preparation, your friend's preparation, nothing. If you want to ask your friend, talk about what movie you will watch after the exam, right? After the exam, shall we go there? Shall we go here? That's the only conversation you should be having. Don't discuss, and most importantly, don't panic. Don't do a post-mortem before the theory papers are complete. Sometimes I see, people come out and then they go, oh, shit, I knew it, and then, they kind of become very despondent, and then gone, half a day gone. Right, they'll be like, I'm not feeling like reading only. And tomorrow you have an exam. So you cannot let 100 marks and one question for 10 or 20 marks dictate your rest 300 marks, right? So that won't happen if you don't kind of, do this foolish thing of just going back immediately and doing a post-mortem. There is a time for post-mortem. I'll tell you when to do that. That is before your practicals. Because in practicals, they'll sometimes ask the questions which you have not answered correctly, but not before all your theory papers are over. Then, how do you construct a perfect answer to a 20-marker question? So, one thing you have to understand is, keep the faith in yourself. After 3 years in psychiatry, you will be very much able to know something about everything or any topic that is asked. Second, although the main question seems main, and it is for 20 marks each, sometimes I have seen students do these fundamental mistakes. They keep writing main question for about 2 hours, and then they realize after 2 hours or 2 hours 10 minutes that I have only answered for 40 marks out of the 100, and I still have to fight for the remaining 60, but I have only 45 minutes, and then I have so many questions to answer. So what I suggest to some of you who will have difficulty in time management is flip. So start with the short note answers first. Write all those things. Tell yourself that within 1.5 hours, I'll finish all the short note answers. And then the remaining 1.5 hours, 45 minutes, you can give to the main question. But before answering the main question, give 2 to 3 minutes solid, calm, peaceful time wherein you again write the skeleton of the answer. Very, very important. Don't start writing. Don't vomit on the answer sheet immediately as soon as they ask something. Because then you'll realize, oh, this should have come here, that should have come here. This argument could have been better placed over here. So frame the answer and the responses so that it becomes better. That is how you become better. So the sample skeleton for a critical review question, like for example, you might be asked, is psychotherapy going to be redundant in the coming 50 years? Critical review, right. So then you should talk about an introduction, like psychotherapy, how it evolved, how it is an important aspect of psychiatry. And then you talk about the nosology or the historical roots as to what is the first generation psychotherapy, second generation psychotherapy, transdiagnostic psychotherapies, effect sizes, then appropriate stats. What is a meta-analysis of psychotherapy? Is it evidence-based? What does a network meta-analysis show? Is it as good as psychotropics? In resistant stages, like for example in OCD, does psychotherapy have a role like ERP? Talk about it. And then you talk about the uniqueness of applicability, especially in vulnerable population if it is relevant to your topic. Then you speak about any female specificity, funnel shape specificity. Funnel shape specificity means you kind of start with a very broad base as to what you're trying to answer and then bring towards the synthesis of what you're actually trying to convey. And finally, you talk about the Western data and the Indian data, and the last paragraph will be a synthesis or a summary. Therefore, I believe that psychotherapy will never go out of vogue because it's one of the most important tools in the armamentarium of a psychiatrist. Okay? And then you speak about 1 or 2 lines on the future directions. Very, very important is to have a lot of algorithms in your answer, right? Nobody likes to read paragraphs. Your examiners really do not have the time or the patience to search for the answer within 10 pages of what you have written. So algorithms and then having text or line diagrams, simple line diagrams, all of these things will become very, very helpful. Have subheadings and bullet points as well. Don't just quote something randomly. Psychotherapy has an effect size of 0.80, much better than any known psychotropic known to man. Don't just quote, because people will know, okay, this is something that is not right. Don't even quote something or somebody else has said if you're not sure about it, right? For example, if you know a quote which is that, for example, let's say, psychiatric emergency, acute dystonia should always be handled with an urgency. It is an emergency. You came up with that quote yourself. Tell it has to be handled on an urgent basis. Don't write somebody else's name just to appear like you have read some top scientist or something. Avoid circumstantiality. Don't go beating around the bush. If they are asked specifically close-up in augmentation strategies, don't talk about schizophrenia, Bloiler, first-rank symptoms, then how it evolved as a concept, schizoaffective disorder, Kasanin, and so don't do that. They don't like it. So speak specifically to the point, right? At best, have 4 lines as an introductory paragraph, and that's it. Get to the point very quickly. Precise, short answers are much better than long, imprecise answers. Mind you, that once the examiner is making impressions of you, isn't it? Right? So once he sees 1 or 2 questions, hey, this fellow, unnecessarily blade fellow is, So that by the time 3rd or 4th question you have answered well also, they'll be like, oh, blade. Like they'll be like, okay, let me. So it's very, very important that you should not bias the examiner in a negative way. Suppose you give a sophisticated algorithm, diagram, start with a quote, end with a synthesis statement. Such an organized answer. I'm very, very happy. And then they get into that positive mood about your responses. So for the practical exam, now for the final leg of the practical exam. So as a student, you hope that only easy cases will be kept. Yeah, obviously, they know that, my teachers are very nice to me. You expect, some of you might expect only tough cases. My HOD hates me. Hates me means literally hates me. He didn't even give me permission to attend the CME, right? So both of these are biased, wrong perspectives. And some of you think that only language compatible cases will be kept. No, sometimes it might be this patient from West Bengal who has a very difficult psychopathology and multiple diagnosis, and it's kept in front of you and you don't speak a word of Bengali. Might happen. And then don't think that the patients and attenders will be very cooperative, right? One of my colleagues who actually took exams with me, first thing patient did as soon as he entered the examination room was lock himself up in the toilet. And there was no other case. The examiner said, you try taking that case. So for 10 to 15 minutes, this girl is going on, sir, will you please come out? I'll just talk to you. I won't do anything to you. Please come out. And finally, because she had read about how to handle difficult situations, she managed to convince the patient. The OSCE task was actually to elicit an important psychopathology in an uncooperative patient. She got very good marks. So if you have been exposed to these kind of difficult scenarios in your post-graduation, it will become very, very easy to handle. In reality, any case can be kept. Usually, the patient and the examiners will be prepped. Patient and the caregivers will be prepped about the diagnosis. For example, if we feel it's a Bengali patient and I'm keeping this case and I know that none of them speak, I'll say, okay, TK, you should probably tell that, once they elicit your history, you'd probably say that I've been tried on many medicines for about 2 to 3 months. It hasn't really helped me. In fact, at one medicine, I don't know why they gave it, but after that I developed seizures, right? I developed. So we'll prime the patients. So you know that it is either clomipramine or clozapine that we are talking about in this particular individual. So some amount of priming will happen, but not like the patient won't say, sir, मुझे OCD है और फिर resistant है, दो anti-obsessionals की failure हो गई है, अभी तो clomipramine भी चढ़ाई पर fits आ गई, तो उसके बाद तो क्या फिर बस therapy अभी वो भी काम नहीं कर रहे हैं. They won't come and tell you like that, right? So they won't be primed to that extent. They'll be primed to some extent. Then understand that the external examiner will already have a formulation in front of them. So it's not that they won't know anything about the case. They would have chosen the case. In fact, my MD examiner is sitting in this very room. right? The one who gave me a gold medal. I'll speak about sir a little bit later. But it is important to understand that they would know A to Z about the case. Okay, so you should not try to kind of, do something very, very funny. Then you don't please never ask the diagnosis from any SR or other assisting faculty who might be there, because they might not know it, and number two, it might be wrong. In that mistake, if some miscommunication happens, your exam can go horribly wrong. Trust your skills. You are good enough to actually pick up the diagnosis. It's okay if you give a differential of schizophrenia, schizoaffective. The heaven is not going to come down on earth because of that. So please remain patient with it. And golden rules to follow is that yesterday's session and today morning, what all has been taught to you in this CME are something that is very, very important. How to formulate a long case, how to present a long case, how about EG and psychological assessments and radiological findings, how to actually do that. One howler which I've seen students perform is, I am going to give one high fundu a kind of diagnosis to my examiner. I'm going to impress them. And then suddenly 3 years they have never diagnosed somebody with disruptive mood dysregulation disorder. Suddenly in the exam, sir, my diagnosis is disruptive mood disorder. The examiner is stumped. What is this person talking about? Okay, tell me criteria. And then like, okay, criteria, adolescents, disruption, mood dysregulation happens. And then how are you going to manage it? Sir, mood stabilizers, antipsychotics. So you are actually kind of, digging a grave for yourself. Very important golden rule for excellence in psychiatric postgraduate examination is, don't do on the exam what you have not done for 3 years. Don't do anything surprising. Don't do anything shocking in the exam. What you have been doing in the 3 years is what will be tested. So keep the basics concepts right. Then, if you have time to write a formulation, because you will be assessed based on a formulation. You will be going on and on about the history. The examiners would have turned off their brain. They will be worrying about when the flight is there, when should I actually finish jotting down all these marks, and then when I will go back to my hometown. These fellows in NIMHANS, they don't even give a good accommodation. So they will be thinking about 100 and 1,000 different things. So as students, it's very, very important to understand, but the moment you say formulation, 100% attention. The examiners will know, okay, now we are coming to the meaty part of the history taking in the exam. So be very careful. So if you get a chance to write a formulation first, write a solid management plan first, after the formulation, and then only start writing your history. Some of you do the reverse. Start writing your history. I want to present well. I want to talk only on and about the history. After 3 years in psychiatry, people are not happy just to see you diagnose a person with schizophrenia. Right? That is not enough. They want to know how you will manage this case. They want to know today, if they pass you tomorrow, will you kill a patient or not? To put it very bluntly. Right? And for that, they need to know what are the management strategies you have formulated. Some students I have actually kind of seen get into this habit of self-googly. I call it a self-googly because bowler is a simple off-break bowler. Okay, simple bowler. These people, some students actually tell, the examiner is asking me this question because they think that what I am saying is not correct. So the opposite must be true. So they kind of, keep common sense aside, logic aside, what they have read aside, and try to change everything, thinking that this is the reason why. Don't do all that harakiri in the examination. Examiner is asking you a question, it is based on logic. No examiner will come there and put googlies to make you clean bold. That is not there. They have greater, their achievement is much, much more in life. So for them to come to an examination is to pass you, is to help you, is to ensure that you become a good psychiatrist, right? So they are not worried about showing their intelligence by throwing a googly at you. No examiner will throw googlies. Please remember that. And remember the 4 P's in your formulation: precipitating factors, perpetuating factors, personality factors, and protective factors. Give a solid formulation, diagnosis with a differential diagnosis, and put, if you have time, points in favor of a particular diagnosis, points against a diagnosis, and then proceed with your management plan. Neurology case, do not jump into an etiological diagnosis. For example, one of the cases that was kept for our examination was SSP. So the student presented the cases, sir, my diagnosis is subacute sclerosing panencephalitis. The examiner was extremely unhappy. How are you so sure? You don't have the radiological findings with you. All you have is that there has been no immunization, and right now the patient presents with a dementia, with a myoclonus, with epilepsy. So when you get this particular kind of complex pattern, especially in neurology, do not go to an etiological diagnosis straight away. Talk about, okay, what I'm dealing with here is a neuropsychiatric syndrome characterized by these findings. Given the age of the individual, the past history of no vaccination in childhood, possible etiological diagnosis could involve something like SSP, although I would like to keep the differential diagnosis of HIV, so on and so forth. And comply with the instructions. Do not try, in OSCE, do not try to do anything that is not asked from you to do. Always remember that OSCE has a beginning, middle and an end, and you will be assessed on all three, right? How you begin an OSCE is also very important. They'll call the patient and ask these, they elicit judgment in this particular patient. The examiners will be viewing where you will sit, whether you lean forward, whether you introduce yourself to the examiners, so to the patient, whether you introduce the examiners, whether you asked for the patient's comfort and assured confidentiality, and whether you set the agenda for the OSCE by telling, I'm just going to be talking about this. And then whether you summarized, paraphrased in the middle part, and by the end actually told that this is what I have understood. Have I understood you properly? And then whether you finish it well by saying, thank you so much for your cooperation and time. Is it okay if you go back and wait outside while our team actually gets back to you and takes you safely back to the ward? So once you do all of these things, that's going to be helpful. You know how some of the students do OSCE? They examine judgment and like, what do you want to do in the future? You have psychiatry illness? Yes or no? Yes, okay. Sir, patient wants to buy a property, says that there is nothing problem with him. And they don't look at the patient, or patient is looking, they ask 2 questions, there might be some 2 or 3 more questions. They look at the examiner. Some other students do the other wrong thing also. Something happens, patient is like starts crying and then they're suddenly, sir, they look at the examiners as if the examiners will jump and say, Kanda, what happened, like I'm here to help. No, see, you're supposed to navigate those problems, and then please be aware that these problems can happen. Sometimes some patients will bring in some radically different thing in the OSCE task. It will be a simple, straightforward schizoaffective disorder. Suddenly the patient will say, actually doctor, you have spoken to me so well, I want to talk about my childhood trauma. History only was not there, childhood trauma. Then in front of the examiner, and then OSCE is finishing, 5 minutes was given, they are pressing the bell. Okay, finish up, wind up, and then childhood trauma came up. How do you handle? Very, very important to navigate this by saying, such an important thing that you have brought up. I am sure that in the coming 5 minutes, I will not be able to do justice to this. Is it okay if I come back to you and talk about this in the ward? Because I really want to be fully attentive to this. Right now, what you have spoken is about all these things. Have I understood you correctly? Rest assured that I will come back and talk about this in the ward. Examiner is happy. Right? That is ethics. So if you were there in the other position, you would expect the same, right? You want to tell something that you would want your wishes. It should not be like, as doctor, I want to talk about my childhood trauma, and then you are like, judgment. You talk about judgment. What do you want to do? Whether you want to go to IIT and pursue your parents, that is what is important. So it's important. It's very, very important to have these important skills, right? And please stick to what has been asked in the OSCE task. If I have said examine judgment, you don't go to the examiner and say, okay, right, Mohan, right? Why have you come here? And then, don't start with an open-ended question and say, what are your symptoms? What about your childhood? Don't go all the examiners will be very irritated with all these things. They have asked you, so you should say, Mohan, we have already met before and we have actually discussed how you suffer from these problems. I had one doubt which I wanted to clarify. Is it okay if I speak to you about this? Right. So that is how you set the agenda for the OSCE task. Tip number 11, prime the patients for OSCE, especially if the psychopathology is a bit dubious. Sometimes you are still not sure, delusion of misinterpretation or primary delusion. The patient sometimes says, this started first, this started first, this started first. Then you prime the patient by saying, when you are taking the long case itself, that Mohan, remember that you are telling that this is the thing that started first, right? Have I understood you correctly? I might ask you this question again, at which point of time you will say this is the thing that started first, correct? So Mohan will come and then actually answer the same chronology. Sometimes it helps, especially if there is very difficult psychopathology with dubious things. Also, if you have informed the patient and if your long case is also going to be an OSCE task, which is how it is in most centers, and if you tell them I'm going to meet you again, wherein I'm going to be discussing the select aspects, they come eagerly and then you start with it. I'm happy to actually kind of meet you again, as I had told you before. Their rapport is very easily established when compared to not having briefed them earlier. So the OSCE stations, there is the unmanned OSCE that I'm talking about. You can take a snapshot of it. Usually, people will actually ask one unmanned OSCE on addiction at least. They can, for example, put a photo of naltrexone or buprenorphine and ask you questions related to it. or disulfiram and ask you questions related to it. One station will be on, say, consultation liaison psychiatry like thyroid, autoimmune thyroiditis, syphilis. One question will be on forensic psychiatry like POXO, MHC amendment, so on and so forth. One will definitely be on rehabilitation and benefits. That is something that you need to be aware of. One will be definitely on child psychiatry. So you need to read about all these assessments and laws related to the same. In the basic neurosciences and applied psychology, you should know scientists. See, there are only so many scientists who are important in basic neuroscience. So know them, see their photo multiple times, and then side profile view, front profile view, everything you keep multiple, because that's what will be actually shown in the examination. Then you will be asked variants of Stroop test, variants of Rorschach, and then you need to kind of inform that. Brain sections will be given with anatomical localization, you should be able to do that. HPA axis might be given, or other neuroendocrine kind of diagrams can be given. Nobel Prize winners also might be asked. So this is something that you need to be well versed with. So this is how your examination is going to happen, wherein you have got a good night's rest. That is the most important thing. And then your case, you will be given about 45 minutes for the long case. You will be given about 20 to 30 minutes for the short case. Please understand that if you are feeling very jittery with the long case, to calm yourself down, sometimes it might be helpful to say, my name is so-and-so, and I'm going to be discussing a few details. Is it okay? Just to calm yourself down, start off with a general physical examination within 2 to 3 minutes. Just so that these are things that cannot be dubious, right? So within 2-3 minutes, you start checking their pulse, BP, weight, height. Additional advantages before the general physical examination, their neurological kit, everything becomes busy. You'll be able to finish it off, and then you can start off. Okay, now I want to talk a bit about why we are doing this. This is an examination. I want to ask you a few questions in detail. Is it okay? And then you start with your thing. Mind you that sometimes, unfortunately, if you are the first student going into the exam, you will only have 45 minutes. So please be prepared with a formulation at least, and management plan at least you can improvise on the go. If you get time, first write formulation, then management plan, then go towards writing the history. Don't forget, please don't forget these howlers, and don't commit them in the examination. Howler number 1 is, if you have missed out that the patient has actually received ECT in the recent admission or the current admission. And if you think that that has actually happened, the examiners will think that they have not elicited enough history. They don't even know that the patient was given ECT at any point of time. Are there any legal issues ongoing? Because it will add another dimension to your case. It's a very important question to consider. Suicidality or homicidality, especially suicidality, you cannot miss out in the exam, right? And patients won't report it because of the stigma. So you need to kind of inquire about it with all your cases. Substance use also is very, very important. And treatment resistance is something that you need to figure out, and adverse effects to any medicines. Has there been any medicines which you found to be intolerable, especially to the extent that you had to be investigated for it, especially medicines which made you to have significant hand tremors, neck twisting, seizures, excessive salivation, constipation for very many days, or else jaundice. So you are covering very many serious adverse events, so that you don't miss out on it, because that can be the reason why this case is kept in the first place. So you miss out that this patient was admitted for lithium toxicity and just present it as a bipolar affective disorder. The discussion points are going to be very limited, and that is not something that is good. Lastly, also inquire whether the patient is pregnant. Once a simple case of catatonia was kept for the final exam, the only aspect of which the patient missed out was the patient was actually pregnant for 4 months. With a 4-month pregnant lady is not visibly pregnant, isn't it? So therefore, because they missed out, the entire discussion which was supposed to be on perinatal psychiatry, psychotropics and perinatal psychiatry, got limited to catatonia, and then they went on from discussing Bush-Francis to alternative scales in catatonia, what are the rating severity, and so on and so forth, and it became a very tough exam for this individual. So don't do that. Tip number 12, no basic rating scales in psychiatry. Very, very important. You have to make a table like this. Okay, this is not the full table. My table is actually runs to about 3 or 4 pages long. So the rating scales table should have what is the scale that you are talking about, who is the author of that scale. Like for example, first scale is PAN-SS. PAN-SS stands for? Okay, it's a question that will be asked. So then who has actually given the scale, where is it used, what are the dimensions, what is the maximum score, minimum score, so on and so forth. Very, very important. So rating scales table you have to start making now itself, depending, irrespective of which year you are. Then if you want to aim higher, some of you said, you are aiming to actually to do more than just pass. Ensure that you have done well in your theory and written OSCE, because that is non-negotiable. Also, do very well in your practical viva, because it will have a latency effect as we talked about. And also hope that you don't, so sometimes you do need a bit of luck that you don't get a very complicated case, but if you do get a complicated case, rest assured that the discussion will be kept at a simple level by the examiners. Please don't spend too much time in your presentation on HOPA and MSc. If you are a good student, if you have read well for the examination, don't spend too much time in your HOPI and MSc. Very, very important, because you want to show how good a clinician you are, and that will only be assessed by management plan. If you are a not so good student, if you are a student who is actually kind of, not sure at all, you are very, very unsure about the diagnosis and everything, spend more time in the HOPI and the MSc, because you want to be asked questions on psychopathology, you want to be asked questions on FRS and primary delusions and so on and so forth. You are limiting your discussion with the management because you are not so sure that this case, what is the management plan, because it's a very unique case, like for example, body dysmorphic disorder, which you might not have seen in your 3 years of postgraduate residency a lot. So Viva, it is very, very important to read the weak spots from the theory exams. So after all your theory papers are over, usually one examiner will ask you questions on history of psychiatry, popular persons in psychiatry and community psychiatry questions. One examiner will be focused on psychopharmacology. One examiner will ask on core psychiatry. And the fourth examiner will ask things like psychiatric emergencies, risk of suicide, classificatory systems, assessments, so on and so forth. So very, very important, and this is tip number 13, which is important for your Viva, which is create a stats and a number database. So the moment you see any number, right, in any of your textbook guidelines, it has to go into a Word document that you have kept on your desktop. It's like stats Word document, okay? The risk of death with schizophrenia is, completed suicide in schizophrenia is 10% in the first 10 years. Where is it given? Okay, it's given in your CTP, put it into your stats folder, right? This Word document. In the end, you will realize that you would have only got about 4 or 5 pages of document, which is so rich with statistics and numbers, and that you already jotted it down in one place from various amalgamation of different sources with citations for that. You become very, very strong and competent in your Viva if you are asked this question, right? I was asked a question about clozapine related adverse effects in my Viva, right? Not only did I talk about the adverse effects, I talked about what is the percentage of these adverse effects. Sir, one of the commonest adverse effects of clozapine is, hypersalivation, is sedation. In fact, liver function abnormalities might be associated with 40% of people who are prescribed clozapine. Because I knew this 40% to 50% number from my Maudsley and I had written it down, I answered, the examiners are happy. They might check, but once they check that it is correct, they'll be happy with you, that you know these numbers. So create a stats and a numbers database. So it can be something like this. I'm sorry, it's not displayed very well, but the numbers are actually something that will help you during your Viva. You should also write down important timelines for things like suicide-related legislation and important suicide-related study that has been done in India, especially the million death study or the intercept study. It's very, very useful because this is one topic that will definitely be examined by the examiners. So therefore, you need to create again databases for the same. Tip number 14, and I'm coming to the end of my presentation. You need to know about the historical figures and the achievements, which are very important and essential. So what you can do is, in Wiki, you just type Wikipedia, top psychiatrists in history. You will get this list very easily. So what you do is you copy that list and add 2 or 3 points about this particular psychiatrist or mental health professional or neurologist, because before psychiatry there was neurology. So, and what they have actually done and how they have contributed to our field. It is very, very important. Once you have this, again it is going to be very helpful for your Viva and will help you excel. Viva Pearl, it is very, very important. Please try to understand, you will not, I repeat, you will not be able to answer 100% of all the questions asked by the examiners. Examiners will keep going until they reach a point wherein you do not answer anymore, right? So that doesn't make that a bad Viva. That just ensures that that you are getting given more chances. If you don't know the answer to something, don't be in a haste to say don't know, right? This is a pearl that I have actually kind of I am teaching you. This is a slight jugaad. Okay, there are 2 ways to say you don't know. One way is when you are asked a statistics, what is the risk of suicide with schizophrenia? Immediately say, I don't know. Makes you appear very coarse, unrefined. With such callousness, he is saying, I don't know. You might think I am saying I don't know so that I will get one more question, so that I will actually move on to the next question. Instead of that, wait for 2 to 5 seconds. Risk of suicide with schizophrenia. Sorry, sir, I'm not able to recollect it. I'll come back to it. And then you're leading the examiner to ask you another question. Once you do recollect the answer to this question, you can say, sir, I now remembered that this is the risk. So by saying bluntly, don't know, don't think that you are given more chances. It is making the examiner to judge you in a negative manner. On the other hand, don't keep making the examiner wait, right? Risk of suicide, you know, right. And then, that silence, the longer the silence in your viva, bleak is the prognosis. Okay, so very, very important. Any silence more than 2 to 3 seconds, you should quickly do something to ensure that you are talking. Otherwise, you are in a risk. Okay, but at the same time, answer after 1 or 2 second delay because your mind will work better. So, calm assurance versus overconfidence, there is a very thin line. Overconfidence is this. I know, and I'm going to answer you. So the examiner will think that, okay, and then they will ask something which you will not know because their experience in psychiatry is 10 times more than yours. That is why they are examiners. So don't be too overconfident, saying that, this I know, sir. So try to be with a calm assurance. Sir, this is what it is, this is what it is. I think that this is the reason why this study is famous. So they know that, okay, you know your answers. At the same time, you are assured about the same and you are not being too cocky or arrogant in the exam. Read about antipsychotics, which is very important for the viva because part of the evaluation of psychiatry and the validity of psychiatry has been through the eyes of antipsychiatry movements. Most of what they say is rubbish, but some of what they say is something that we should introspect on because it has led to the advancement of our science. So without a biased outlook, read about these R.D. Lang, David Cooper, and then also about Thomas Szasz, John Reed, and Joanna Moncrief. The latest Joanna Moncrief article caused quite a furor, isn't it? There she spoke about blood levels of serotonin and how antidepressants don't increase them, how antidepressants are a farce and stuff like that. Read about them so that you know what she did wrong and what was the rebuttal to it, what was the rebuttals given by experts in the field, and what was the correct response to such a testimony, right? Don't say, when examiner asks you, talk about antipsychotics, antipsychiatrists, don't take Tom Cruise. Okay? Many students do that. He is an antipsychiatrist, of course. But we are not worried if Tom Cruise is an antipsychiatrist or not. First, speak about important people like Lang or Cooper or Szasz before you speak about celebrity figures who are antipsychiatrists. So to conclude, I want to actually introduce two terms, that is obitory and wabi-sabi. Obitory is something that means bloom at your own pace, right? 3 years of post-graduation is a sufficiently long time. It is 3 important years of your adult life. Sometimes it takes a bit of time for you to learn these things. Not all of us are blessed to come from high-funded English schools. First time you open these fish sims and all, half of the English you won't understand. What is this fellow talking about? You'll be wondering. And then, and to top it off, they use German word, Geden Kenlot Warden, Echo de la Pensi, are the 2 types. So, who cares, man? Tell thought, echo. Okay, enough. Why do I need? So, before you learn to understand all these intricacies, right, understand that you have your own pace. You came from a difficult background, it is okay. Give yourself time. Don't compare yourself to the next person who is coming from some elite schooling, who's picked up on all these things. Keep being process-oriented. Today your history might not be adequate. Tomorrow it might not be adequate. Keep doing things over and over and over again, process-oriented. By the end of 3 years, you will get to where your hard work always pays. Second thing is wabi-sabi. There is beauty in imperfection. No matter how much you study and whatever you do in the exam, there will be some wrongs. But it is okay. Be kind to yourself. You are not a perfect human being. The exam is meant to motivate you to study, and that is all that there is. And all of you will pass your exam if you have worked well for 3 years. That is all there is to the examination. The art of excellence is an art and not a hack. If some of you expected this person will talk about some jugaad of what to do to pass in an exam, no. You cannot do jugaad and pass in the exam. You might get away with 1 or 2 questions, but the examiners are so brilliant that they will know how to actually pry out the good people from the not so good people. So please remember that it's an art which you have to develop over 3 years, and therefore I started from first year and my last slides were on the viva. Then success in exams is just a byproduct. What is important is you learn psychiatry, you are enjoying psychiatry. You get an opportunity to come and discuss with young colleagues if you do well in your examinations and talk about what went well for you. Maybe next year or the next year to that, once you become a faculty, you will come here and talk about what went right for you. and you will enjoy teaching. You will also help your patients by learning psychiatry. Exams are just a byproduct. You will clear it, right? That is not the most important thing. Then one day you will soon be a consultant, researcher and a teacher, and all these efforts that you put in, day in and day out in your 3 years will be handy then. And then you'll reframe or build your own expert template in these coming 3 years of post-graduation. This is something that should provide a structure for you to help through your preparation and your examinations. My acknowledgements to my teachers, to both from NIMHANS and from all over India, especially to my teachers at NIMHANS and Professor PSVN Sharma, with whom I have discussed quite a bit of these things. And to NIMHANS, which has provided us an opportunity to learn and come and help us grow and then help others also grow through some of the challenges that we faced. And most importantly, to all my students over the past decade and the Tamil Nadu chapter of the Indian Psychiatric Society, Panner Selvam sir, for inviting us and giving us an opportunity to share some of our experiences. My young colleague Nurul Hassan for keeping the trust in us that we could come here and contribute to you. Most important to all of you who know that lunch is served and still you are patiently waiting till the last slide so that it might help you. Thank you so much. This is my email ID and that is my Twitter account. I keep tweeting about important things in academic psychiatry and research. In case you want, you can follow me on Twitter and you can write to me in case you have any doubts. Right. My examiner is Anand sir. So he's the one who was there for my MD examination. And so some of the experiences I have shared are from personal experiences and experience of my colleague. Very nice to see you here, sir. A privilege.
Yeah, it's an excellent presentation. I think, yeah, as you said, like, okay, so people have stayed back for a long period, and then, like, I think each and every slide of yours is really good. I think the PGs really enjoyed. I'm really happy to see you. I was really impressed and really thank you.
Thank you, sir. Thank you so much.
I request our chairpersons to honor our speaker, Dr. Suhas sir, for enlightening us about this topic.
Before honoring him, let him honor. Okay, I will keep talking about you.
Really nice, man. Really nice. Yeah.
He has brought me the journey from my student period to my teaching experience as an assistant professor and as a professor and as an examiner. Whatever I went through, it's been clearly delineated by him that all these things will happen to you also, and you will also experience the same thing. And what is very important about the examination is not only the examination is for excellence and it's for testing your things. Anyway, we are going to pass at any one point of time. That is not the issue. But how to get the excellence that starts right from your first year onwards, not at the last. So you have to train yourself from the first year. And in the examination, the one particular thing which I want to highlight, which is the very famous question by each and every examiner to give a excellence for you. What is your topic of interest? And in that topic, you should be knowing A to Z. A to Z. Nothing, no compromise in that. If you answer that, yes, you are given the excellence. And that is one area where the examiners, as an examiner, when we sit, we expect this to answer. And this answer is done fully. Then all your long case presentations and Viva OCR, OSCE and other things will complement this. And this will give you the excellence. And this is from my point. And thanks for your excellent presentation. And everyone should add, and I think this lecture should be recorded and it should be displayed in each and every medical college of MD post-graduation psychiatry, so that they also can train themselves right from the beginning how to train instead of having in the last minute preparations. Thank you very much.
Yeah, I couldn't really resist having lunch.
I saw the people, nobody moved out. And I also didn't feel like having a lunch because he was taking me the journey right from my my association with him in NIMHANS.
We didn't ring the bell at all, and sir prevented from ringing the bell. Let him.
All these fellows were attending the exams. I was SR there. How we prepared, how Raghuram used to be as an examiner, all those things, and how we behaved as an examiner. All those things. It was very well presented, and we know how you got all the best outgoing because of this, I think so.
Yeah, now I remember his long day's presentations.
I request Dr. Nurul Hasan sir to honor Dr. C. Bhaskar sir and Dr. Ramanujam sir to honor Dr. Siva Ilango sir.
ஆனந்த் வாங்க, நான் ஒரு குரூப் சேர்ந்து எடுத்துக்கிறேன்.